Welcome back to Quick Hits in Laboratory Medicine. I'm Rob Fitzgerald and have the pleasure of talking to you for about the next 10 minutes, interpreting creatinine and urea in common disease states. We gave basics of creatinine and urea in a previous slide set, and now I'm just going to talk about how you interpret these in some very common clinical situations. One of the powerful aspects of laboratory medicine is the ability to identify specific processes that are going on. And when we think about renal issues, we can differentiate those into tubular dysfunction versus glomerular dysfunction. And so we're going to talk a little bit about tubular function studies, which primarily revolve around kidneys' ability to concentrate things. We're going to differentiate prerenal, renal, and postrenal azotemia, and in part we're going to do that by looking at SUN to creatinine ratios, which typically are in the 10 to 20 range and differ in these various disease states. And then finally we're going to talk about acute glomerulonephritis, and that's a disease where you have inflammation of the glomeruli, oftentimes caused by a sore throat, streptococcal infection after a latent period where the immune complexes have deposited it in the glomerulus and are causing inflammation and subsequent damage. Chronic glomerulonephritis is a long-term disease process. Maybe your patient has diabetes, and they've had insults to their kidneys for years, and they're on the pathway to developing end-stage renal disease, and their laboratory values are quite striking and reasonably easy to identify. Nephrotic syndrome, the take-home message there is really you're talking about a single mechanism, and that single mechanism is leakage of protein. And in this case, we're talking about albumin, and how does that affect the rest of your lab values. Pyelonephritis is simply an infective process, and we're going to find lots of white cells and things like that, and we'll go into a little bit more detail. So tubular function, as I mentioned, helps us differentiate between tubular disease and glomerular disease, and most often we're talking about concentrating ability. And so a couple of limitations that we need to be aware of is what is the hydration status of the patient. If they're dehydrated or if they're overhydrated, then that's going to have an effect on their concentrating ability, at least as what should be showing up. If they're overhydrated, then the kidneys functioning properly are going to excrete a dilute sample, and so that's not going to tell you anything about the concentrating ability. However, if the urine specimen is concentrated, that says the tubules are working. They're reabsorbing fluids, which is what their primary function is. We measure it by looking at osmolality, and that's a colligative property typically done by freezing point depression, and tells us how many solutes are in a kilogram of water. Higher indicates concentrating ability, indicates tubular function. Same thing with specific gravity. Blood-specific gravity is about 1.008. It's essentially a density measurement. And if your urine has a specific gravity of 1.20, your tubules are working, unless you're giving them glucose or something else that's being freely filtered. Again, with specific gravity, if you have a consistent specific gravity of 1.008, around that range, between 1.008 and 1.012, something like that, we call that isostenuria. And sometimes that's an indication of impending renal failure, and inability to concentrate or dilute a urine specimen. And so that's something to keep an eye out for. We're going to use SUN to creatinine ratios a fair amount in this brief section, and just wanted to remind you that the normal range for SUN to creatinine ratio is about 10 to 20, 12 to 20, something like that, depending somewhat on the patient's diet, because SUN, serum urea nitrogen, which is where we measure it, people talk about it as BUN, blood urea nitrogen, but in fact it's always been measured in serum, so the proper term is really SUN, even though many lab hospital systems will report it as BUN because that's just historical. Azotemia really means increases of urea nitrogen. And so increases of urea nitrogen in blood is azotemia. And in prerenal azotemia, your kidneys are working fine, but you have azotemia because you're not getting enough blood to the kidneys. And so decreased cardiac output is a common cause of that. The kidneys need about 1/5 of your cardiac output in order to function properly. And if they're not getting that, then you're going to get prerenal azotemia. And so how do we differentiate prerenal azotemia from renal azotemia? In prerenal azotemia, your kidneys are working fine, and so your creatinine clearance, whatever's coming to your glomeruli, is going to be filtered, and your creatinine is going to be cleared. And so typically with prerenal azotemia, your creatinine doesn't change, but since you have decreased flow through the kidney, it's going to cause decreased flow through the tubules, which is going to allow your urea to be reabsorbed better. If your urea is reabsorbed better because of the low flow through the tubules, your blood urea goes up, but your blood creatinine stays the same, and your SUN to creatinine ratio goes high. So in the cases of prerenal azotemia, your SUN to creatinine ratio might be 30, but your creatinine will typically be near the normal range. That's different from renal azotemia. In renal azotemia, you actually have insults to the kidney, and in that case, you're not going to clear creatinine as well, and both your creatinine and your SUN are going to go up. In that case, your SUN to creatinine ratio, you would think if they both go up, that it wouldn't change, but in fact, the urea nitrogen goes up higher than your creatinine, so you do get an increase. But you can differentiate it by looking at the creatinine. So in the cases of prerenal azotemia, your creatinine typically stays in the normalish range, whereas in renal azotemia, your creatinine is elevated, along with your SUN to creatinine ratio. Postrenal azotemia is if you're blocking urine flow, you're going to reabsorb urea, you get azotemia because of that. So acute glomerulonephritis, as we mentioned in the beginning, it's often related to an infective process. There's a latent period where the immune complexes are depositing on the glomerulus, causing inflammation, and that inflammation damages the kidney. And so when you inflame the kidney, you increase gaps in between cells so that blood cells can actually get through the glomerulus, and you get hematuria. That's red cells in the urine. Sometimes you can get red cell cast. Cast is an imprint of the tubule. Your tubules are secreting this protein called Tam-Horsthoff protein, and if you have a whole lot of red cells, they can be trapped inside this protein complex and excreted as such, and that's fairly characteristic for acute glomerulonephritis. You're going to find a lot of red cells in that same situation. You'll have mild proteinuria. And so the kidney is designed not to filter proteins, and so you have protein in your urine is not good. And so mild proteinuria because of the inflammatory process. Patients become hypertensive because they're not clearing fluids correctly. They get interstitial fluid buildup and edema and azotemia. So labs that you're going to find are an elevated urea nitrogen and elevated creatinine. The SUN creatinine ratio goes up because the urea goes up higher relative to the amount of creatinine that goes up. You get acidosis because one of your main functions of the kidney is to maintain acid-base balance, and you get a buildup of acids. You also get hyperkalemia is also a very common finding in kidney injury. We talk about a selectivity ratio, and that's useful because IgG has a molecular weight of about 150 kilodaltons, whereas albumin has a molecular weight of about 68 kilodaltons. And so if you're selective in that you're primarily excreting albumin in the urine, you're better off than if you're excreting immunoglobulins, which are more than twice as big. So the selectivity ratio, if it's less than 0.15, we call that minimal change, and oftentimes patients recover from that. Whereas if you have poor selectivity and you're excreting both immunoglobulins and albumin, and that has a poor prognosis. Switching to chronic glomerulonephritis, and so this is this is 10, 20 years down the road, disease that has been present for a long time. Serum chemistries, you're going to get uremia because you have decreased flow through the tubules, and you're going to reabsorb that. So your urea nitrogen, your creatinine, and your uric acid go up. You're going to be hyponatremic because the kidney is unable to maintain fluid balances, and you retain water more so than sodium. Hyperkalemia is typical in these patients. They have potassiums in the 6 range and above, because one of the important functions of the kidney is excreting potassium. Hypocalcemia because of no active vitamin D. How the mechanism behind that is that vitamin D is sequentially hydroxylated. It's hydroxylated in the kidney, and the mechanism for activation of vitamin D is a sequential hydroxylation, a 25 hydroxylation, and then the kidney puts a hydroxyl group in the 1 position to form 125 dihydroxyvitamin D, which is the active hormone that has an effect on increasing calcium. So in the case of chronic renal failure, you lack that 1 hydroxylase and you don't have any active vitamin D. Hyperphosphatemia, because of the hypocalcemia, your parathyroid gland senses low calcium, increases PTH, which is going to break down bones, and you're going to try to increase the calcium, and along with that you get an increase of phosphate. Acidosis is common because of the inability to excrete both organic and inorganic acids. Elevated alkaline phosphatase, and in particular that would be the bone form of alkaline phosphatase, again related to the hyperparathyroidism due to the hypocalcemia and lack of vitamin D. In this case, your SUN to creatinine ratio is typically less than 10. And so, again, why does that happen? If both creatinine and urea are elevated, how does your SUN to creatinine ratio go low? And that's because over the course of years, you've been losing urea, and your substrate is essentially gone, so your SUN to creatinine ratio is less than 10 in the cases of chronic glomerulonephritis. So on urinalysis, you're going to find proteinuria. You can find hematuria, so red cells in the urine. Oftentimes, as we talked about, these patients become isosthenuric, and where their specific gravity doesn't change much, irregardless of fluid status. And essentially is saying that their kidneys, both their tubules and their glomerulus, is not working. These patients become anemic because one of the functions of the kidney is synthesizing erythropoietin, and without erythropoietin, you don't synthesize new red cells. Nephrotic syndrome, there's a whole bunch of different labs that are associated with it, but they're really caused by one single factor, and that is loss of protein in the urine. So massive proteinuria, up to more than 3 grams a day. And in particular, the protein we're talking about is albumin. So if you're leaking protein in your kidneys, you're going to become hypoalbuminemic. So you have decreased albumin in the blood. One of the primary functions of albumin in circulation is for oncotic pressure. Typically in the arterioles, if you don't have albumin, then you don't reabsorb water into the arterioles from the interstitial space, and you get edema. Your body compensates for that by increasing synthesis of these hyperlipid proteins, these lipoproteins, and so the consistency of the serum sample changes from being a straw clear sample to being very lipemic, where you can actually see these VLDLs in the serum samples. So as we talked about, edema is present because of the oncotic pressures. The estrogen to creatinine ratio is typically normal, and the GFR is normal. So in nephrotic syndrome, you're really just leaking albumin, and if you remember that, you can figure out the rest of it. Acute pyelonephritis is an infective process. So you've got an infection of the kidneys. Urea, nitrogen, creatinine, uric acid are all normal. Your estrogen to creatinine ratio is normal. Your GFR is normal. But on urinalysis, we're going to see lots of white cells. The urine will be cloudy. You could have some red cells. Under a microscope, you can actually see the bacteria in the urine sample. And from a hematology perspective, you're going to see an elevated white count. So that's a quick review of laboratory findings, in particular urea and creatinine in common disease states. And I hope you'll tune in for another quick hit in lab medicine.